concepts and challenges. So humans, if we can throw what humans can throw, apes and other animals or something, they can't throw the velocity or the pace with which we are throwing. So humans are definitely have a high precision and high capacity, high strength in order to throw certain objects with a particular velocity. Okay, and we have evolved from apes. So initially we were struggling to use our weapons to hunt animals, but eventually we evolved, and look at that, we became a little more stronger, and then we are able to throw better. And that strength and that evolution we incorporate in sports recently. So if you compare the scapula position between the humans and the monkeys, there is a lot of difference. So the orientation of the scapula is, look at that, on the right side it is the scapular orientation, and whenever the monkeys or apes try to hold on to something or to perform some activity, their orientation is above 90 degrees, whereas humans, whenever we involve in throwing something, it is always below 90 degrees. And look at the orientation of the pectorals. Okay, so for apes, the orientation of the pectorals is a little more superior in order to accommodate the upward rotated scapula, whereas in humans, the sternal fibers of the clavicle or the sternal fibers of the pectorals are oriented horizontally. If you compare the right and the left was the pectoral major of the humans and the right was the pectoralis major of apes, chimpanzees. And this is the orientation. The right was the orientation of the scapula in apes, whereas the left, it is the orientation of the scapula in humans. So what humans can do, what humans can't do. Humans can throw any object with a greater velocity. And the velocity with which they throw, for example, if it is a baseball, if you take, the velocity is almost 170 kilometer per hour. Unimaginable, isn't it? And if you ask any other animals which are close to humans, they won't be able to do this. Okay, but what we can't do is, we can't hang on to, bark of the trees, or we can't hang, or we'll say it is a brachiating. So we won't be able to do brachiating if you compare the left and the right picture, whereas the apes can easily brachiate better. And then they swing from one place to other place for the branches of the trees. So what helps in that? The evolution has helped in that. The evolution of the human shoulder, it has helped us in order to perform a particular sport-related higher velocity with precision, so that we can involve in a lot of sports. So this is the orientation of the scapula of the chimpanzee, left side, and right side is the orientation of the scapula of a human being, right now, after evolution. So if you see the ribs of humans, right now it is barrel-shaped for us, whereas it was almost triangle in terms before, probably millions of years ago. It was triangle when we were evolving, and now we have a barrel-shaped chest, which helps us in producing a lot of shoulder movements. So look at this. So what is that? The red color, if you see, the house painters, they tend to get a lot of shoulder pain when they involve in specific activities for more than 12 months. Because these painters, most of the time, they end up in activities with more than 90 degrees of shoulder abduction. Whereas other people, if you see machine operators and car mechanics, it doesn't demand much of shoulder movements beyond 90 degrees of abduction. So there is a big difference. Okay, so what does that indicate? This indicates that people who uses or who work, who load the shoulder too much with more than 90 degrees of shoulder abduction, they are more prone to get injuries. Okay, and what are the other evolutionary changes? What actually helps in providing an efficient, faster throwing movements, whether it is a javelin throw or whatever it is? We got Neeraj Chopra. Okay, he is from a specific background. Okay, if you see his background, his gene is completely different, who is meant for throwing. That's why he was able to achieve gold medal for us. And what contributes in the pelvis is attributing significantly to the evolution, and that has evolved significantly, and it helps us in producing excessive shoulder movements. That's why it helps us to excel in sport with precision and with greater velocity. So now if you see this picture, we say the pelvis and the spine is called as the spinal engine, which is going to initiate. So this person doesn't have limbs. He doesn't have upper limb, he doesn't have lower limb. So basically he is walking or he is sitting on the ischial tuberosity and he is walking on that. What actually initiates the movement is not the legs. It is the spine and the pelvis which acts as an engine and then helps him to progress easily. Okay, so spine and the pelvis is most important aspect in the shoulder movements. Clear? Okay, so now if you see this tennis player, if you analyze that, the tennis serve has different phases. The first phase is the preparatory phase where the tennis player prepares himself the moment he initiates the movement till he reaches the maximal external rotation of the shoulder. Look at that. Now that's the end of the preparatory. And after that, it is the acceleration. And after the hitting the ball, it is deceleration. So there are three phases. So one is preparatory, where he starts from the beginning, as soon as he initiates the movement, till he reaches maximum external rotation. That is the preparatory phase, followed by your acceleration phase. He accelerates from maximally external rotation position to internal rotation position. So this movement is very significant for shoulder movements and any overhead shoulder activities. Okay, and at last you end up in deceleration movement. So these are the three phases which are key in determining a better overhead sporting activity. Okay, so what happens? Your shoulder generates only 21% of the force. So that means when you are serving or when you are doing a smashing, okay, the majority of the force is coming from lower limb, which is transferred through the trunk to the shoulder. So when you have an issue with the trunk or when you have an issue with the pelvis or the lower limb, that might get transmitted to the shoulder. So your shoulder has to work too much in order to produce force. Eventually what happens? A lot of micro trauma happens and you will end up in injury. Getting it? So in this case, if someone comes to you with a shoulder pain, will you treat only the shoulder or you will treat it as a whole, as a movement system? What do you think? Because shoulder is contributing only 20% of the force. That means somewhere, the source of pain is somewhere, the source of the problem is somewhere because of which you are getting issues in the shoulder. So instead of looking only at the shoulder, you have to look it as a whole movement system and then focus on improving the strength. Okay, so focusing only on the shoulder in order to treat the shoulder pain is not a great idea. You have to look into the whole system, treat it as a movement. So that is what we say is a kinetic chain. Okay, if you see this, look at the orientation of the pelvis, look at the force generated from the legs, from the pelvis, which gets transmitted to the, finally to the javelin. So it needs the entire kinetic chain to work, and it has to work in a sequence, and then it has to generate it to the, it has to be transferred to the shoulder. So if you see here, in both the early late cocking phase, which is in external rotated position, and in the just before the release phase, again it is an external rotation, which is the crucial part. Okay. So the critical moments, late cocking phase and early deceleration phase. So these two phases are the crucial phase. So if someone, cricketer, comes to you saying that I have shoulder pain when I throw from boundary line, basically you might have to look at his throwing mechanics in order to understand exactly what happens. Okay. There are so many challenges we face. Relevance of clinical assessment. Now, problem with this special orthopedic test and imaging, there are two issues. Okay, so let's see this special orthopedic test. So we have got a lot of tests. They have introduced some new tests as well. That's wonderful to hear that. And these people said some knees test and can test, empty can, full can, whatever it is. But what about the, what is the evidence says about that? A review of the special test associated with the shoulder examination, rotator cuff test, all these knee impingement, Hawkins, and rotator cuff tests, so many other, yeah, hundreds. These special tests are not special, okay? Actually, it can provocate pain, but it doesn't show which structure is involved. So there is no point in doing all these tests in the future, okay? So that's different. So it can test. What they said is empty can, EC, full can. So in this, you can't isolately activate any test. So the empty can and full can test do not selectively activate supraspinal test. We always say supraspinatus tendinitis, tendinosis, tendinopathy, whatever it is there, We always say that empty can is positive, full can is positive, we'll say supraspinatus impingement. But it is not so. Okay? So these tests do not satisfy basic criteria and not a great valid test. It is not a diagnostic tool for tests. Okay? She's supraspinatus, infraspinatus, teres minor and subscapularis. Those are the muscles. But do you think, is there any difference in that? Everything is connected, isn't it? So, because the anatomy is like this, it is impossible to separate or differential diagnose that which segment is affected or which tendon is affected by using your special test. Clear? That's the take home message. No more special test for the shoulder. So next, so the tendons were found to splay out and it interdigitates between together. Everything is interconnected. So you can't structurally differentiate these tendons. Done? So first challenge is what? You can't make a definitive clinical diagnosis. Second one, imaging. Shoulder pain, 283 people they have taken, and in that, 65% with rotator cuff tears had no pain. Means what? They will randomly take people and then they have no pain, but they had rotator cuff tears. 65%. Okay, take home message 2. So asymptomatic rotator cuff tears. So many people are having, they're asymptomatic, no issues. I don't have any problem with the shoulders. Scan. Asymptomatic shoulder abnormalities were found in 96% of the participants. 96% of the participants. Tear is there, but there is no, the ultrasound shows tear, but there is no symptoms. Take home message, important. Now, okay, leave ultrasound. Let's go to the MRI. What does MRI say? So they have taken subjects with subacromial impingement syndrome and then the subjects without subacromial impingement syndrome. And in that control group, for example, asymptomatic group like you, almost 52% had rotator cuff pathology. Normal people like you and me who doesn't have any problem with the shoulder, but when they just do an MRI, they found that there is 50% of us had issues. So what is the take home message here? Imaging can't exactly reveal the source of pain. Posture related. Posture is that some people are kyphotic, some people are excessive lordotic, and people will think, okay, you have an excessive kyphotic posture, your shoulder pain is because of the kyphosis. That is a usual tendency we tend to develop. Okay, it may not be right. Okay, what evidence is? No evidence to support the scapular posture, and have you heard of this scapular dyskinesis? Scapular dyskinesis. So what is this? Posture doesn't follow defined patterns. So whether scapular dyskinesis is there or not, whether you have an excessive kyphotic posture, there is no concrete evidence that there is a relationship between these two. Clear? Take home message 3. What was the take home message 1? Clinical evidence, special tests are not special. 2, don't rely on imaging. Don't rely on MRI, don't rely on ultrasound. Third one, don't keep on checking the posture. People are having different posture. Okay? Next is relevance of shoulder impingement. Okay. So, Neer's impingement test you must have heard, isn't it? So, he's the one who has proposed that Neer impingement test. So, in 1972, he thought that shoulder pain, everything is because of the compromise in the subacromial space. Either it could be bursal inflammation or that rotator cuff tendon is getting impinged. So what he did from 1970 to 1983, he did a lot of studies and he reported that 95% of tears of the rotator cuff are caused by impingement. So any rotator cuff tear, impingement is responsible. So what he did, if there is an impingement, what they do? Acromioplasty. They cut open clavicle, they remove a little bit of clavicle, remove a little bit of bursa, they remove the entire bursa called as bursectomy, and coracohumeral arch. So they remove everything. But because of this studies, what happened is there is 746% increase in the number of surgery from 2001 to 2010. That subacromial decompression surgery for rotator cuff disease. Is it okay? Let's see what the evidence says. Evidence shows that subacromial decompression does not provide clinically important significant difference. So there is no benefit over your normal rehabilitation. Subacromial decompression surgery provided no benefit over placebo. So finally they concluded, a group of people worked on it and then they finally concluded patients should avoid surgery as there is no extra benefit from the surgery. Clear? So take home message is what? You need to push the patient as much as possible for not undergoing surgery. Just because MRI is saying that, don't send them for surgery. Clear? Take home message 5. So does shoulder impingement exist? That only we have to think. May not, because so if I do this normally, even from 60 to 90 degree, there is an impingement. Usually in almost 50% of us, when we do this movement, the supraspinatus impinges with the coracohumeral ligament, okay, with the arch, okay. And people think that above 90 if you do, we tend to get more impingement, but that is not correct. So there was no difference between the symptomatic and asymptomatic subjects. Contact was maximum at 60 degree of elevation. So we think that more than 90 degrees, we get a lot of compression. No, it is not so. Because even at 60 degrees, you have a lot of compression. So we see the different distance, acromihumeral distance, no relationship. So no relationship between the acromihumeral distance and the pain in adults. A lot of factors are there, kinetic chain factors, psychosocial factors, biomechanical factors, lifestyle factors. Exercises is as effective as surgery. So better not to undergo surgery, number 1. Subacromial impingement syndrome, exercise significantly reduces the need of surgery. If you do proper rehab, you can prevent surgery. Full thickness tears, again, exercise is as effective as surgery. Full thickness tear, exercise is as effective as surgery. So main things what you have to consider is you have to educate the people. It can't be fixed immediately like this. When you are doing rehab, please make sure that you progressively increase the load. Okay, and then otherwise what happen? Loading will be too much and you will end up in pain. So slowly, based on the inter-individual differences, you got to progressively increase the load. Make sure that they sleep properly, no smoking habits, good physical activity, good strength, improving the strength, range of motion, mobility, everything you have to work in the rehab. So kinetic chain. As I said, shoulder, you don't treat only shoulder, you treat the entire kinetic chain. So for example, if you see the hip orientation and the shoulder orientation completely different, isn't it? So there should be some separation between these two in order to effectively perform. So X factor angle, look at this. This is the difference between the elite player on the left side and novice player on the left side. Elite player have a tendency to separate the shoulders from the hip effectively, whereas the novice, he is not able to do. So his force delivery won't be that much effective. So efficient kinetic chain, one by one it acts. So the force starts from the legs, transmitted to the hip, and then transmitted through the trunk and finally to the shoulder. So if any problem with any of the structure can impact the shoulder. Clear? So one by one it acts. It's a hip pivot, collar pivot, and a shoulder pivot. So kinetic chain, everything, all the force has to be summated and it has to act in sequence so that it can effectively transfer to the shoulder. Inefficient kinetic chain, whenever there is a problem with other segments, it can affect the shoulder. So that is what is ineffective kinetic